Greetings. Hi, everyone. Thanks for allowing me to speak about my favorite drug, not just recreation. So I've been given the impossible task of speaking about ketamine in the 4 different ways that it's going to be used in under 30 minutes. So we should probably get into it. No disclosures. I never do. So while we gaze on some really awesome Spanish rock, I'm going to talk about today. I can't even see this. I'm going to talk about some core concepts of ketamine use. So I really want to kind of emphasize the concepts. I want to talk a bit about evidence. Don't have time to go into too much evidence, and talk about some of the ways, the aspects about using it in the 4 different ways, and then talk a little bit about some theoretical and practical stuff, especially in the critical ill. This is a slide of mine that's been making the rounds lately. I think a lot of you have probably seen it. And it's kind of true. There's lots and lots of things to love about ketamine. Like, you can give it multiple ways. It's fast, it's analgesic, preserves your physiology, usually. But there's a balance where there's a lot of effects that annoy people. There's the adverse effects, and there's a lot of fear out there still about using ketamine. Like, how many people here are a ketamine fan? Better question, how many people are not yet a ketamine fan? Speaking to the converted. Anyway, I spent a lot of time lecturing on ketamine, trying to tip the balance towards the positive aspects of it. One of the key concepts, actually there's 2 key concepts about ketamine use that you can really take advantage of when you're using it. And this is something that's important to have a firm grasp on, not just when you're using it clinically, but when you're teaching people to use it. I think it's really important to keep the concepts in mind. And the first concept is the dose-response spectrum, what's been coined as the ketamine brain continuum. And we all know that the effect you get from ketamine depends mostly on the dose that you pick. And so when you're deciding to use ketamine, you need to have a goal in mind. You should know ahead of time, what is it that I want to achieve? If it's analgesia, you're going to play in the low zone, under 0.4 primarily. As you push the dose up, it gets recreational. Most people like it. Who here has had ketamine? No bona fide, really. I did. Oh, a couple of hands, awesome. Anyway, recreational effects are very well known. It makes it pretty popular. As it gets pushed higher, you get partially dissociated. And of course, when you take it to the extreme, you're fully dissociated. Ketamine is still the most used anesthetic worldwide. General surgery with no monitoring, tens of thousands of times yearly. The big concept is ketamine is very, very reliable when you use it in the extremes. In the middle, you don't know what you're going to get. This is something you have to know about before you use it. It doesn't mean you won't go into that middle zone, but you have to know that the effect is not going to be reliable. So taking advantage of the low dose is the analgesic stuff, of course. Ketamine still has a very bad rap. A lot of people fear its use, a lot of people hate it. A lot of that is through these overblown reports, I think. I think part of the problem is when people get bad effects, they tend to be quite legendary. So everyone's heard of a bad ketamine response, not everybody's seen one. But the really bad stuff, you really don't have to think about it when you're using it for analgesia. And this is how it can be used in low doses without all that sedation-style monitoring. In fact, you don't need any monitoring at all. This is really put on the map by Jennings, a pre-hospital study. A lot of these studies are all the Australians are a decade ahead of us in pain research. This is one of the early studies that showed that when you use morphine along with a low dose of ketamine, you get superior analgesia. So ketamine not only led people that require less morphine, they also were more comfortable. This is followed up very recently in the emergent literature by Montov. This study's been getting a lot of play. He compared not ketamine with morphine, but ketamine head-to-head against morphine, and found that, in kind of the usual analgesic dose of 0.3 per kilo, you got equivalent analgesia within half an hour. Interestingly, and you'll see this in a number of studies, the pain relief seems to be faster when you use ketamine. It comes with a cost. Not only do you get faster pain relief, but you also get faster side effects. And quite a few more, actually. So all these side effects tend to be quite minor. Dizziness, disorientation, people rarely need to have anything done. In fact, almost never have to have anything done about the side effect. And once again, just like the analgesic effect, it kind of washes out after about 30 minutes. And you see this repeated over and over again in the literature. Earlier pain relief, more adverse effects, especially early, both effects level out by about 30 minutes. He followed the study up with a very interesting thing where he did this double-blind, double-dummy design looking at slower delivery of ketamine to see if he could reduce the number of adverse effects. And it worked. So compared to IV push over a couple of minutes, he did a slow infusion over 15. The double-dummy design means that everybody got the corresponding placebo in every group. A big reduction in the number of adverse effects, cut it almost in half with no difference in analgesic efficacy. Another interesting study was done by Baudouin. I guess it was American, be Baudin, wouldn't it? But I think he's French, so we'll go with Baudouin. He was looking at the balance between the dose, the efficacy, and the adverse effects. Looked at morphine and placebo, and added 2 doses of ketamine, the usual 0.3, and then half of that. In terms of analgesic efficacy, you got significantly better analgesia with both doses of ketamine. Slightly better with a higher dose of ketamine. Not statistically significant, but the study wasn't actually powered to show that. But probably more analgesia, but quite a lot more adverse effects of the higher dose. So, quick summary on that is that with ketamine, your analgesia is faster. It's synergistic with opiates. You definitely can spare opiates. You get more adverse effects, but you have higher satisfaction scores. That seems to be pretty universal. 0.3 is probably better than less than that. But you do get significantly more adverse effects. Both doses will give you significant analgesia. So if you want to minimize adverse effects, you can use a lower dose. You can give it slower or give a bit of sedative. You have options. A lot of you know me as an intranasal kind of guy. And actually, I've actually received intranasal ketamine when I had an orthopedic misadventure. There's a long story that I'll tell you sometime. But when you're using intranasals, and when you're teaching people how to use intranasals, there's a bit of theoretical aspects that are important to keep in mind. One is that you really want to take advantage of the particle size. It's all about using the atomizer. It's all about pushing hard and fast to get those small particles and spread that over the nasal mucosa. And there's the concept of the nose-brain pathway. It's not just absorption through the nasal mucosa into the bloodstream. They actually get direct absorption through the olfactory nerves directly into the CSF. And that's purportedly one of the big ways that intranasal medications work. Keeping the volume small is key. And this is another way that Australians are a decade ahead of us. They get ketamine and fentanyl in double the concentration that we have available in North America. So they keep the volumes low. Under 0.5 ml is optimal. 1 ml per side will work, but less is more with this. We actually did one of the earliest intranasal ketamine studies. This is an emergency department study. I actually got this idea from the US military because they were looking for an analgesic that's easy to give in the battlefield, that you can give sitting, don't need monitoring. And at the time I said, that sounds a lot like my emergency department waiting room. And so we showed that you can get significant analgesia with 0.5 milligram per kilogram. The problem was more than half the people needed a repeat. So based on this and some other studies, some other smaller ones, the Pitchfork study came out, great name. They looked at fentanyl and ketamine head-to-head. Ketamine at double the dose, 1 per kilo. Similar reductions in pain with fentanyl and with ketamine. And as we see over and over again in the literature, more adverse effects with ketamine, but higher satisfaction scores. This is a recurring theme. The big problem with intranasal fentanyl. Now, intranasal fentanyl has been on the scene much longer than intranasal ketamine, and as a pediatric drug, for obvious reasons, when you look at the effective dose and the way it's supplied, fentanyl is a great drug for really, really small humans, because you can get good analgesia in a single setting. It doesn't work quite as well with adults because you have to give repeated sprays, which tends to be a real pain in the ass. But with ketamine, the dose that, the body size that we can do is much more adult size. And this is what we were trying to take advantage of when we did our pre-hospital study, the PK study, which has just come out this week. Thank you everybody who helped out. We looked at usual care with nitrous, and I picked a dose of 0.75 milligrams per kilogram of ketamine. This was not random. Remember, we saw that at half a milligram per kilogram, a lot of people needed a repeat. At 1 milligram per kilogram, there's a lot more adverse effects. And I was trying to see if 0.75 was kind of the sweet spot between efficacy and adverse effects. And we did find it to be very effective as an analgesic. This is in addition to nitrous. Both groups got nitrous oxide based on the usual protocols. But as we saw before, more adverse effects, quite definitely. All of them are minor, because once again we see more adverse effects, but better satisfaction scores. Moving on to the second thing, the second concept about using ketamine is the dissociation threshold. This is a concept that more is not more. Ketamine is a dissociative anesthetic. It disconnects your brain from the outside world. When you're fully disconnected, it doesn't matter how much more ketamine you give. You'll have the same effect in front of you. I can give a patient 2 milligrams per kilogram of IV ketamine and it'll be fully dissociated. If I give that same patient 20 milligrams per kilogram of IV ketamine, I have the exact same patient in front of me. Ketamine is unlike almost any other sedative we use in that regard. And when we're using it in high doses, we're really trying to get full control for whatever purpose. And it might just be the ideal agent for full control, because you can get full control in a single dose. You don't have to have an IV. It's fast, has lots of good effects like analgesia and amnesia. It doesn't mess with your adrenals, maintain your airway, and it's usually good for your hemodynamics. I would put the word usually in there. And we've known about it in the emergency department for ages. We've been using it for RSI, for a long, long time. There's been head-to-head studies with etomidate and ketamine. It works great. It definitely spares the adrenals. Does that matter? It's a different story. But the big problem comes when you get the shocky patient, and this is where people get really trepidatious with ketamine, because everybody knows that the critically ill don't tolerate anything well, especially anesthetics. And with ketamine, it's all about the direct myocardial suppression that you get with ketamine. This has been shown in vitro studies, where if you have an isolated system, you give ketamine, you decrease contractility. That is true. But it's also sympathomimetic, because it prevents reuptake of those catecholamines. It also causes some release of catecholamines. So if we give ketamine to any physiologically normal person, that direct myocardial suppression just doesn't matter, because the net effect, the blood pressure goes up. The trouble is, the critically ill are sometimes not intact. They don't have that compensatory mechanism. They're catecholamine depleted, and of course, if they're completely hypovolemic, it doesn't matter how much myocardial stimulation you provide. If the gas tank is empty, it's just empty. Then you intubate them, you add some positive pressure ventilation, and this is how people totally end up in the weeds, right? And we've all seen it. So that's why your protocols reflect a lower dose of ketamine in the shocky patient. And when the decreased LOC, even half that dose. So the problem is predicting what's going to happen. How do you know if your patient is going to crash? The best evidence out there was actually put out by Miller just a couple of years ago. He used a shock index, and slightly different than what's in your protocols. But he used a shock index of 0.9 to indicate high shock index, and under 0.9 as being low, and found that if you have a high shock index patient, 0.9 or above, your chance of hypotension is much more. Oops, how do you go backwards? That doesn't matter. High shock index patients, blood pressure will still go up, usually, but there's a significant number where your blood pressure will crash. And this is where the idea of using a low dose of ketamine, gauging the patient response, and then moving forward from there comes about. And it makes some good sense. A lot like the DSI approach promoted by people like Scott Weingart, where you've got a compromised patient, you're going to give them a small dose of ketamine, you're going to gauge the response, and then move forward based on that response. And you know, if you're using a paralytic, we call it DSI. You're giving aliquots of ketamine to your patients just right, then you paralyze and intubate. If you're not using paralytics, then that's called, then you monitor as KSI, which is also a way to go. Maybe a little bit more difficult without the paralysis. And using the small aliquots of ketamine to get your patient just right is a lot like the way you can use it for procedural sedation. So pull this out of your protocols, you know, give an initial dose of 0.5 per kilogram and see how your patient responds. Can you anticipate a potential problem? Right in that middle zone, right? So it's only a problem if you're not prepared for it. And that's why I say, when you're using ketamine, know what you're trying to achieve, know what you're trying to, the endpoint that you're trying to get, and know what problems can happen as a result of that. And if you're prepared to deal with it, it's not a problem. Most people, when they get into that middle zone, they actually like it. The problem is that people that don't like it can be really, really extreme. Everybody in your postal code and the next will hear about it. And that's why I think ketamine has maintained this kind of fearsome reputation. So the question always comes up, why don't we just give them midazolam prophylactically? People have looked at that. In kids, no benefit at all, because kids are much more resistant to those bad adverse effects. But in adults, it actually does make a difference. So if you're really concerned about that, if a bad reaction will really drive you nuts, giving an adult 2 milligrams of midazolam is perfectly reasonable and evidence-based. The other way we use ketamine in high doses, you know, for that full control is an excited delirium. I don't want to talk too much about this because people are going to talk about it tomorrow. Other than to say, ketamine just might be the ideal agent in a lot of people's opinion, just because it's so fast. When you need control right now, nothing is faster, and speed is really safety. It's fast, full control. We give it to people right through clothing. Do no need to strip them down. We went over this all in an editorial a couple of years ago, and giving ketamine in very high doses for behavioral control is not risk-free, because the patients that you're giving it to are not risk-free patients. These patients are physiologically deranged. It's a mixed population. Anything you do is fraught with risk. If you don't do anything, that's fraught with risk. So this is for the patient where you have to take action, and that's where speed is your friend. Just remember to go big. A couple of quick shout-outs. One is for the concept of GCS3K. A lot of studies that have come out kind of giving ketamine a bad reputation. Like, more people get intubated when they receive higher doses of ketamine. This concept of GCS, 8 must intubate is, when you give ketamine in a full dose, your patient's GCS is 3. but that's a ketamine state, that's dissociation. So as people become more familiar with the dissociative state, become more comfortable with it, I think you'll see those initial concerns kind of fade away. And the other shout out is to the study that I'm involved with Dave Barbick at St. Paul's. This is an emergency department study looking at high dose ketamine compared to halomidazolam for agitation control. People love to talk about things that can go wrong, so I love to talk about it too. So, in times I've seen ketamine being used, and times that I've used ketamine where, you know what, it just didn't work the way I thought it was going to, it's almost always the dose. It's always the dose. If Jack doesn't go down, it's because you didn't give him enough. I've seen this happen two ways. There's a natural human tendency that if you're using a drug, especially if you're early on in your experience with it, you know, they say it's 5 milligrams per kilogram, but I want to be careful. And careful usually means giving a little and seeing, and just, I want to be a little, you know, dip my toe in the pool. And that's just shooting yourself in the foot. If you're going to be careful with ketamine, you should give 10 milligrams per kilogram, because then you can be 100% sure of what's going to happen in front of you. There's lots of good literature out there. 4 milligrams per kilogram is really a minimum dose. We've used that in pediatric sedation for many, many years, but when you look at those original pediatric dosing studies, 4 milligrams per kilogram gives you behavioral control in 90% of individuals. When you use 5 milligrams per kilogram, you're talking about 98% reliability. So if you're worried and you need to contain this person right now, go big, aim high. Laryngospasm is one of my favorites. How many people have seen laryngospasm to ketamine? As have I. How many people had to do something other than wait? How many people had to do something other than wait and then bag? Ah. Who's done the Larson maneuver? Awesome! Does it work? Yeah. I've never had the opportunity to try it. I've seen laryngospasm a number of times. It often just goes away. It's pretty simple to bag through. I've never had to do anything further than that. It needs to swear by this maneuver. I've never had the opportunity to try it. So, one person tried it. More than one person's tried it. Did it work for you? Didn't work for you. Damn useless. In your laryngospasm, when you look at the literature, it really seems to be an idiosyncratic reaction. Back in the day, we thought, oh, patients with an upper respiratory infection is, the secretions tickle the larynx. It's when you manipulate the upper airway. It's when you do this. It's when you do that. There's been no association shown. Hypersalivation. Who's seen problematic hypersalivation? How many people had to do anything other than suction?
Just somatropine.
Just somatropine. So, really problematic hypersalivation is pretty rare. 1 in 1,000 happens. Be ready to deal with it. Prophylactic atropine, that's been brought up many times, doesn't really save you any problems. Recovery agitation. Can I take the next minute and just tell you one of my pet peeves?
1 minute.
1 minute? Damn. Okay. Emergence reactions is not a term. It should be recovery agitation. And because a lot of times when people are agitated, they're not recovering from anything, you just got up too high. But anyway, everybody's got to recover. If you use ketamine in big doses, they're fully dissociated, the levels have to come down. You got to go through that zone. What do? You can give them some midazolam, talk nice, or just give them more ketamine and talk to them and deal with it later. Who has seen extreme rigidity to a point where you can't even bag the patient?
Steven.
Wow. What a guy. Yeah, it can happen. It's really, really rare. This is pretty frightening. It can be really difficult to sort out from a seizure. But you can almost always bag a patient. If you can't, you just have to do what you have to do. But if that ever happens to you, please publish the case report. It's so damn rare. So in summary, using ketamine, have a goal. You want to use ketamine's properties to your advantage. Know what you want to achieve before you dive in. Be careful of that middle zone. Doesn't mean you don't have to, can't go there, just be ready to deal with it. Think Diaz. Oh, just think big dose. That's what I'll say. Do we have time for a quiz?
Yes, you do.
Oh, we have time for a quiz. Okay. Most important reason for using ketamine. Most effective? Safest? Fastest? Shortest duration? Nobody's buying.
All the above.
All the above, not impressed.
It will make you sexy and very, very desirable. Come on. Of course, it's the last one. And this is evidence-based. This is evidence-based. Human specimen prior to using ketamine. Same human specimen after using ketamine. No joke. Thanks very much.
Thank you.